Hi, my name is Amanda Yeager, and today I'd like to speak with you about tumor development in endometrial cancer. In a January 2014 article in Obstetrics and Gynecology International, authors Day and Bradford report that endometrial cancer is the most common form of female reproductive cancer. There are over 40,000 new cases diagnosed annually and over 7,000 deaths each year in the U.S. alone. Risk factors are many. It's important to consider lifetime estrogen exposure when thinking of risk factors. First, early menarche results in an increase in the number of menstrual cycles a woman has throughout her life, thereby increasing estrogen exposure. Also, nulligravid status means that a woman has never been pregnant, and in pregnancy, there's a rise in progesterone, which opposes estrogen, and therefore decreases the risk of development of endometrial cancer. Other risk factors include late menopause, hormone replacement therapy, or SERM therapy, such as tamoxifen. Also factors like obesity, because estrogen is stored in adipose tissue, PCOS, diabetes mellitus, smoking, and ovarian cancer each can increase the risk. Interestingly, use of an IUD, as well as younger age, history of breastfeeding, which reduces estrogen levels, low-fat diet, and active lifestyle, all of these reduce the rate of endometrial cancer. Genetics also plays a role, though there is some controversy in the exact role it plays. Familial clustering is recognized, as described by Jeff Boyd in his 2005 article in the Journal of Clinical Oncology. Though there is debate as to the actual site of the location of the genetic mutation, he describes that hereditary non-polyposis colorectal cancer, or HNPCC, is the syndrome considered by many cancer geneticists to be the only manifestation of hereditary predisposition to endometrial cancer. However, others believe there is a genetic site specific to endometrial cancer development. In terms of tumor development, the most common type of endometrial cancer arises from the glandular cells and is termed adenocarcinoma. As described by Drs. Banzel, Yandluri, and Wendham in their 2009 article describing the molecular biology of endometrial cancer, this was published in the Moffitt Cancer Center Journal. These tumors are classified into type 1 and type 2. Type 1, or endometrioid, represents over 70% of new cases. This is the type related to estrogen exposure, as described earlier. Type 2 is not related to hormone exposure and is considered to be much more aggressive in its course and carries with it a poorer prognosis. Type 2 includes serous, clear cell, and poorly differentiated carcinoma. In the 2014 up-to-date entry by Drs. Chen and Barrick, the cardinal symptom of endometrial carcinoma is abnormal uterine bleeding. This is most commonly found in postmenopausal women of increasing age. Therefore, complaint of persistent refractory uterine bleeding of any woman under 45, or any abnormal bleeding in a woman over 45, especially any bleeding at all in a postmenopausal woman, deserves evaluation. This might include pelvic exam, pelvic ultrasound, labs to be drawn to rule out pregnancy, and potentially even in-office or in the OR sampling, and then biopsy of endometrial tissue. This might potentially even include D&C to obtain a satisfactory amount of tissue. The diagnosis is then made on histologic examination. The results return in a spectrum, similar to Pap tests. This may range from benign or polyp, or hyperplasia with or without atypia. Of course, any abnormal finding requires referral to a gynecologist. delay in diagnosis dramatically increases mortality. Early detection can reduce mortality and increase the survival rate to over 90%. Some places cite that as over 95%. According to the American Cancer Society, clinicians should maintain a low threshold for the evaluation of abnormal bleeding and tissue biopsy. Patient education on modifiable risk factors and regular physical exam. Together, these things can reduce mortality and hopefully improve outcomes. Thank you very much.